Hi, I'm Nikki. I'm a physio at the NNN. I work in older person's medicine. I'll jump straight into it. It's difficult trying to condense a year's worth of, or over a year's worth of research into a 10-minute presentation, but I'll give it a go. It's all a bit of a learning curve, isn't it? So this is a topic that I chose, an exploration of physiotherapist perceptions and experiences of respiratory compromise in the hospitalised patient with Parkinson's disease. A bit of a mouthful. So we know that Parkinson's is very prevalent in the older population. Over 2% of over 65-year-olds have Parkinson's, and we know that respiratory compromise is clinically apparent in later stages of PD. We know that pneumonia is the main cause of death in the Parkinson's population, and we suspect that respiratory dysfunction is present in the early stages of PD. However, despite this, management is seldom considered in the same detail as these early motor manifestations, and we know that Parkinson's has got high personal costs to the Parkinson's patient, with both an impact on physical and social functioning and well-being. We know that with an ageing population, the prevalence of Parkinson's and therefore respiratory compromise is likely to rise, and the cost of care is already double that of the unaffected patients, so we know that there's even more greater significant impact on health service funding and resources, and that's going to only increase as the ageing population increases. So looking a little bit at the literature that's already out there in looking at Parkinson's and respiratory compromise, there's a range of review articles that look at the nature and theories of respiratory compromise, so what it is, what causes it, that kind of thing. But there's actually only a handful of studies that actually look at management options. So these are the main 6 reasons that they're saying cause respiratory compromise in Parkinson's patients. So dysphagia, impaired cough, respiratory muscle weakness, influence of muscle tone, levodopa, which is the main drug used to treat Parkinson's. They say that could induce respiratory dysfunction, and then decreased physical activity levels as well. So like I said, there's only a small selection of primary research studies that look at management. There's no studies that look at the relationship between physio and respiratory compromise at all. However, physio is implicated in the supportive management of this patient population in neurodegenerative conditions as a whole. There's no guidelines apart from that for motor neurone disease with NIV and motor neurone disease. However, there is guidance out there for airway clearance techniques in neuromuscular conditions. The question is, can we transfer the results we have for physio and neuromuscular conditions over to treatment for neurodegenerative conditions? And at this stage, it's very difficult to do that because we still don't understand the mechanisms that underlie that respiratory decline in neurodegenerative conditions. So really, there's a very limited selection of information out there already. So my study is a qualitative study. It recruited 4 physiotherapists. The data collection techniques were a focus group that lasted an hour and a half, and then each participant collated a reflective diary for 3 months. From an analysis point of view, I explored the experiences with interpretive phenomenological analysis. I can never say that word. And for those of you that don't know much about IPA, it's broken down into 3 key areas. The first being where you look at the descriptive comments that the participants use, so what they're actually saying. The next being where you look at the linguistic comments, so the language they use to explain what they're trying to say. And then the conceptual comments, which is allowing a degree of interpretation into what the participants are saying. And one of the main reasons I chose IPA is because it allows for the researcher's experience to form part of that interpretation as well. So rather than bias analysis, by using my own experiences as a physio working in this patient population, I was able to use it to kind of build on the analysis process even more. So this is the results chart for the study. So broken down into 3 main superordinate themes, and then lots of sub-themes underneath that. Can you all see this? Is it too small? Just about. I'll let you just have a little read through the themes. Okay. So what I'm going to do is just talk through the main superordinate themes, that got a kind of summary of that encompasses those sub-themes as well. So if we look at the first one, which is the physio's lived experience of respiratory compromise in the patient with Parkinson's, then this actually looks at what they thought these patients looked like, what they were, what they were experiencing, that kind of literal experience. And they described a very vulnerable dependent patient group. They talked about observing a wide range of symptoms, so looking at increased respiratory rate, increased secretions, a very fluctuating presentation as well. They talked about the motor signs they observed, so a weak cough, increased tone, frailty, posture often impacted by high tone, alongside the impact of swallow and ageing, and how they impacted on presentation, often as a combined force as well. They talked about their patients that they treat as having complex needs that develop over time, and that the patients potentially might suffer unduly because of advances in medicine. And they've got a real potential to deteriorate quite rapidly, and that actually within the hospitals where these participants work, there's a feel of urgency and lack of control, and that actually the healthcare system under pressure is perhaps one of the reasons for that, in their opinion. So the next main theme was perceptions of the physiotherapist's role. So this is looking at what they feel their role is, what they perceive their role with this patient population to be. And they all described a very reactive response to illness. In fact, they felt quite resentful and frustrated at times, often because of the perceived loss of education and proactivity. They felt that patients didn't know about the presentation, the MDT didn't know about the presentation of respiratory compromise. But at the same time, they didn't know whose responsibility it was, and they felt frustrated about the fact that it hadn't been delegated as someone's responsibility to inform this patient group that they might develop respiratory compromise, and that it is likely going to be the main reason for their deterioration in later life. They talk about their goals of treatment and how these were influenced by the changing demands of healthcare. Now, ultimately, they really want to protect the patient. Despite that being a very deteriorating and irreversible situation, they really wanted to protect that patient population. They talk about their main role being in sputum clearance, and there's a real internal conflict that goes on here when they talk about sputum clearance. They talk about the invasiveness of treatment versus the effectiveness of treatment. So for example, if you think about nasopharyngeal suction, it's quite an invasive technique in their opinion, but at the same time it's incredibly effective and efficient, and there's a real conflict that the participants face over that decision-making process. These participants desire autonomy, but they also are uncertain of their role at times, and that's partly due to the hierarchical decision-making process that they have observed within the hospital teams that they work. So that again, it's that conflict. There's a lot of frustration over knowing what their role is. And then the third main theme, and probably one of the biggest themes, and which kind of impacts most on the kind of clinical implications, is the challenges to care provision. So these participants perceive multiple challenges to care provision within the hospitals with Parkinson's patients. The main thing they talked about was the variance of knowledge and skills within the multidisciplinary team, particularly within healthcare assistants. And they were they weren't critical of that. They felt saddened by that and actually wanted to try and find a way around dealing with it. Very supportive of their nursing colleagues, despite the fact that they felt that actually they didn't always have the same level of knowledge that they needed when they're looking after patients 24/7, so constant. They talked about that knowledge and skill level as being incredibly influential with regards to timing, quality and confidence with which care is provided. So for example, the timing of referrals, maybe to physiotherapy, the timing of medications, and things like hyoscine. Actually, when a doctor's suggesting getting hyoscine to dry up secretions, but at the same time they're asking for chest physiotherapy to clear those secretions. So it's that knowledge and skills is something that they felt was a real challenge to care provision. The next area was that hierarchical decision-making that I've already mentioned, and that sometimes they feel that the decision-making, people who are making decisions didn't always have greater knowledge of the specific, very specific presentation of respiratory compromise in Parkinson's disease. They felt that there was often a disparity in roles. For example, if you think about airways, in some hospitals, physiotherapists can't put in airways, but they can NP suction, whereas nursing staff can put in airways but often refuse or don't feel confident to NP suction. And it's that disparity in role and the background behind that was they seem to think was quite frustrating. The next challenge they saw to care provision was maintaining patient mobility in hospital, and they talked very much about the barriers to that, what they saw as the reason why patients were often staying in bed and not getting out, and the impact that had on the decline and the development of respiratory compromise. They talked about the importance of person-centred care, They all felt it was very important when you discussed it, but actually they found that sometimes with their treatments it was often an afterthought. And the reason behind that is because they couldn't always determine the wishes of patients when they were acutely unwell. There's a lack of clarity in the direction of care in those really poorly, quite critical patients, often towards the end of their life. So in conclusion, we've got a patient group that's got significant risk of developing respiratory compromise towards the end of life. I feel that this study begins to address the lack of research in the area. Perhaps it starts to bridge a gap between clinical practice and evidence-based practice. And the hope is, rather than give answers, it's more likely to raise questions, but the hope is that MDP, multidisciplinary team, will start to find resonance with some of the themes that I've brought up. We describe exposure to distressing and complex presentation. Patients are increasingly dependent on others and potentially vulnerable in the hands of medical advancement. And there's an identification of the urgent need for education and knowledge of both patients and healthcare professionals. Like I say, lots of questions were raised in my study, namely proactively anticipating decline alongside the ambiguities associated with treatment options and end-of-life decisions. So I identified 5 key clinical implications from my study. The first being, is there scope for physiotherapists to be used more effectively within hospitals in this patient group? Second, is there a need for multidisciplinary education focusing specifically on swallow safety and mobility and keeping patients mobile in hospitals? The third, impact of staffing levels and person-centred care. This was something that really concerned the participants. And the fourth, implementing national guidance. So you've got a lot of national guidance out there that looks at the ageing patient in hospitals, but actually whilst it gives that overview, that guidance, it doesn't always give strategies on how to implement that on the shop floor. And that is what the participants are starting to feel needs to happen. And actually from my interpretation of the results, that for me is an area that needs to be addressed. And the fifth one is, and probably one of the most important from the patient's point of view, is identifying priorities of care. Now we don't know if those priorities of care for patients are being identified in clinic situations, perhaps we don't know. The study didn't cover that. But what we do know is in these participants' experience, those priorities of care for the patient weren't being communicated to the physiotherapist dealing with the patient in the acute stage of their illness. Do we need to look more advanced care planning and helping prepare the patient to take more decisions in what is a really crucial and fundamental part of their life and illness management?